No.
We are live now, doctor.
Okay. So, hello everyone. Welcome to episode 5 of YOSI Retina Surgical War of season 2. So I'll just brief up what this is all about. This we started last year for all the young surgeons to show up their cases and learn from each other. And there were 6 episodes last year, and all the finalists, all the winner of each episode went to the final of grand finale in the YOSICon. So this year also it is same with 6 wildcard entry. Today we have 3 great retina warriors. The warrior number 1 is Dr. Akansha Sharma from Ahmedabad, and the second warrior is Dr. Bobizon Tarziba Evi from Osh, Rajasthan, and then the third warrior for today is Dr. Ashul Chawla from Bhopal. In the esteemed war council, we have Dr. Mudit Tyagi, and welcome you, sir. And we have 2 other stalwarts who have been there right from the start, Dr. Devakant and Dr. Kaushik Tripathi from Lucknow and Kolkata. We have me along with Dr. Pranav and Dr. Dipanshu. We are the battle commanders today. And we have 2 intravitreal armamentarium talk by Dr. Gaurang from Lucknow and Dr. Ishfaq from Kashmir. I welcome you all. Dr. Mudit sir, you have 20 points for each candidate. You can send it to me on WhatsApp. And Dr. Devakant and Dr. Kaushik, you have 10 points each for each candidate for the war. And we'll have a 5-minute presentation for each and a 5-minute discussion followed by 5-minute discussion. Thank you. So we can start. Dr. Akansha, you can share your screen and you can start the.
At the end of all the 3 talks, we are going to have an audience poll as well. So
Yeah.
apart from judges scoring, we do have an audience scoring as well. So based on the total of both the scoring, the winner will be announced.
Yes. Thank you.
Good evening, everyone. Sir, shall I start?
Yeah.
Ansha, there is no audio to it.
So please pardon.
The
There is
audio
no
is not
audio.
playing.
Dr. Akansha, is there supposed to be any audio with this? We can't hear
Sir,
anything.
the audio is playing apparently.
None
You
of
can
us can hear it, I guess.
Actually, while sharing your video, you need to share the audio as well. There will be an option of sharing the audio of the video as well. You can probably unshare and reshare it.
Manjula ji, can you help her? And meanwhile, we'll take the second talk.
Okay, doctor.
Yeah. I'll share her number. You can connect with her.
Okay, doctor.
Yeah. So,
No,
Dr.
just playing. I think Dr. Bobizon will be the one.
Yeah.
I think
Sir,
Dr.
is it audible now?
Yeah.
Yeah,
it
yeah,
is.
yeah.
Presenting a case of a 60-year-old poorly controlled diabetic with complaints of diminution of vision in the left eye for 1 year with a presenting visual acuity of hand movements in the left eye with a diagnosis of tractional retinal detachment with vitreous hemorrhage in a case of proliferative diabetic retinopathy and was advised past planar vitrectomy with intravitreal anti-VEGF injection. 3 25-gauge ports were inserted and infusion was secured. Core and peripheral vitrectomy was done and vitreous hemorrhage was cleared. Tabletop tractional retinal detachment was noted. The cutter was initially used to delineate the edges of the fibrovascular proliferation to create a dissection plane. Delamination and trimming of the fibrovascular tissue was carried out, ensuring gradual debulking while maintaining retinal stability. fibrovascular proliferation was carefully engaged using the cutter, and segmentation was performed by cutting through the fibrovascular bands to reduce traction over the retinal surface. However, dense adherence of the fibrovascular proliferation to the underlying retina was encountered, preventing the creation of an adequate dissection plane. Edges of the fibrovascular proliferation were diathermized. Bleeders were diathermized. As a satisfactory plane could not be established, ILM peeling forceps was subsequently employed and the temporal edge of the fibrovascular tissue was grasped. However, due to extremely dense adherence to underlying retina, the point of dissection was shifted to the edge closer to the optic disc to prevent an iatrogenic break. Due to this firm attachment, complete peeling could not be achieved. The residual fibrovascular tissue was judiciously trimmed to the maximum extent safely possible. Additional bleeders were diathermized. Tight 360 degrees PRP endolyser was done. Leftover vitreous hemorrhage was cleared and fluid air exchange was carried out, followed by intravitreal anti-VEGF injection. Ports were removed and case was closed.
Great case, Dr. Akansha. And
Yes, sir.
I would like to start the discussion with Dr. Mujit, sir.
So Akanksha, nice video.
Thank you,
First of all, query, who was the operating surgeon?
Sir, I operated the case.
All right, so just a few questions. I mean, you handled them pretty nicely. But what are the
Thank you.
different things that you could have done when the bleeding was happening? I mean, what are the different maneuvers that you have as a surgeon at your disposal whenever you encounter a case of so much of bleeding, step by step?
Sir, I would start by maybe increasing the pressure to around like 60, firstly, and then wherever uh, I would like to clear the vitreous hemorrhage which is there at present, and then by reducing the pressures again to 30, I would like to see the points which are bleeding and maybe dithermize them.
All right, so the first thing is probably, yes, you're right. You may raise up your infusion pressure. That will help in taking care of the bleeding. Anything
Yes.
that you can do preoperatively, not in this case, but otherwise,
Sir,
that
actually, we had advised the surgery to the patient, and the patient got operated around 2 months after we had advised the surgery. So apparently, he was not the right candidate for a preparatory intravitreal anti-VEGF injection, because sir, it was very dicey in the case whether, when he will get operated, because it was already bad and we were fearing a further crunch or something of that sort. But otherwise, if the patient was cooperative, we could have given a preparatory anti-VEGF prior to make sure that the bleeding at the time of surgery could be minimal.
all
It
right.
can
So
help.
the both valid point, but just for everybody, you are absolutely right in saying it becomes important for us to judge two factors when you think of a preoperative avastin. One, the systemic control of the patient. Ideally, if you get delayed, I mean, you have injected and then there's a gap between your injection and the surgery, then it can be devastating. So you need to be absolutely sure that you will be able to operate the patient in the next few days. Second, it's important for you to visualize the amount of fibroscular proliferation. In this case, like the pre-op, you were not able to see anything. You just had a vitreous hemorrhage and a lot of underlying probable FVPs. So
Yes.
where you are not able to visualize, where you're not sure of what's happening underneath, also it's not a good idea to inject Avastin, because again, you do not know how much of crunch can happen. Preoperative Bs can be important, because that will help you in showing or assessing which are the areas where the vitreous is adherent and what are the areas of traction, so that you can use for your pre-op assessment. But apart from that, nothing else. So nicely done. Now that's it from my end, Karthik. If the
Thanks.
other judges and others have a question, then please go ahead.
Sir, would you leave little bit of FVP at the end, such adherent FVP, or you will trim it all?
So it depends on the location of an FVP. If the FVP is at the disc and you are absolutely sure that you have removed all of your secondary membranes, then you can sometimes leave it behind. I though usually do end up removing most of the FVPs. If it's in the periphery and there's a option or a choice between trying to over trim it and creating a break in the process, or just leaving behind a small residual amount of FVP in the periphery, you can safely leave it behind. You have to be judicious in deciding. It's like a balancing sort of a thing. You have to weigh in what's more important. So if it's in extreme periphery, I do not mind leaving behind some FVP. But if it's at the disc, you should be absolutely sure you have removed the secondary membranes. Otherwise, the propensity of developing an ERM, secondary membranes formation, all of those come into picture. So that can again probably hamper your post-operative outcomes.
So your comments on ILM peeling in these cases, as what was shown in this, should
So I
should share.
usually, yeah, I don't usually as a routine do an ILM peeling in most of my cases. If there's a traction which is there, or if there's an apparent membrane, yes. But otherwise, I do not usually prefer doing an ILM peeling in most of these cases. There's no harm in doing, but the literature is still mixed. The jury is still out. It's a choice between individual surgeons. There are some who do, and there are a lot who don't. And to be honest, there's not much of a difference in outcome between both of them. I mean, Devkan,
Okay,
Kaushik,
Devas.
Karthik, you others can probably add and
You
come.
can say your opinion on ILM peeling in this case.
Sir,
Yeah,
apparently,
Yeah,
sorry.
please. No, Akanksha, please continue.
Sir, actually, like regularly I'm doing TRDs at Dr. Nagpal's place and also at my place. But sir, I personally feel whenever there is a tabletop TRD, the macular region is already very ischemic, and since we are not able to give an anti-VEGF also previously, the chances of bleeding are also very high. So apparently, sir, I would maybe not do an ILM peeling in these cases unless and until, like sir said, if I really encounter a membrane over that area and there is no choice but to do it. But sir, otherwise, I think I would not.
Devas, sir.
Yeah, so see, a lot of things, drive this decision. But I very closely look at the macula. If I see any ERM, a lot of these cases do have these ERM, and at times when you are unable to peel, remove the FVP, also probably the ILM peeling helps in certain cases. So it's very, I mean, it's very difficult to say generally. It's a very individualistic case to case basis decision. Akanksha, very well managed case. I think these are very
Thanks.
challenging and time taking conditions. And as you rightly said, a lot of things, and as Mudit sir also pointed out, a lot of things come into place pre-operatively as well. So I just have a few questions. How do you, pre-operatively work up in terms of that? You said that it was a poorly managed, poorly controlled case. So what is your protocol? You wait for some control to be there before you plan your surgery, or how do you go about doing it?
Sir, apparently, like in this case, the patient had presented to us with vitreous hemorrhage in both the eyes. But upon doing sonography, we realized that this eye was like had a very very bad TRD, and the other eye had only vitreous hemorrhage with very very minimal FVPs. So, sir, we operated the other eye first. Like our criteria at Retina Foundation is that if the sugar level at the time of surgery is below 250 or so, sir, we generally operate the patient. Because sir, in diabetic patients, it is always, I mean, there is some kind of irregularity which is always going on. So we generally operate below 250. And so we operated the better eye first, because we were very sure, like, if we operated like in this case, the vision from hand movement only improved to 660. The reason being that the disc was also not that great. It showed slight pallor post surgery, and also the fovea was already thinned out and ischemic and all of that. So we operated the other eye first. I only operated it, and it improved to apparently 6/9. So after gaining the confidence of the patient, we operated this eye under explained prognosis. But as far as diabetes is concerned, we just make sure that the blood sugar levels are below 250 at the time of surgery. Apart from that, sir, nothing.
Right. Yes, completely. And theoretically, it makes sense to have a good control for some period of time before planning the surgeries. But a lot of
Right.
times, practically, that is not possible, right? Did you consider bimanual at some point in this case, especially towards the end? You
Uh,
had some issue removing, and I could see that there was some pull that was there over these FVPs. So, did you
Yes, sir,
consider
there
that?
was. No, sir, I did not, because apparently it was it was smooth in the sense that I mean, I could manage it in the sense that I realized that if I take it out from the temporal edge, definitely there's going to be an iatrogenic, because even after removing it from the side of the disc, sir, I just couldn't completely get it off. But sir, otherwise, in totality, I thought that it was at an area where if you could just cauterize and leave it, it won't cause any harm. So it was like that way, it was fine. So
Yep.
I did not feel like using a chandelier at that time, and using
Right. Makes sense. So, talking about cautery, do you feel that you used the power was a bit too high? I could see that the burns were too white and large as one would want.
yes, sir.
Yeah.
That could have been the case.
And since Modit boss is here, did you consider glue anytime to stop the intraoperative bleed? And is Modit sir around?
Yes, I am around.
So your comments on using glue in such cases?
So I do use fibrin glue in some of these cases. We have shown that earlier. We have shared those videos also. I can share it in the YOSI group also for everybody to see after this gets done. But for intractable disc bleeders, yes, we have started using a lot of these cases where just one drop of fibrin glue helps in maintaining hemostasis. So we have been doing that. For peripheral breaks and bleeders, we have tried it, but my colleagues have done it actually more than me. Dr. Ritesh Narula and Brijesh have actually done quite a lot of work. They, in fact, did a randomized control trial which got published in AJO where they compared that. I have predominantly used it for disc bleeders, but yes, for those it works very well. Just one drop of fibrin glue and it acts as a brilliant hemostasis agent.
Right. So this is also an option that we could consider, guys. So yes,
Right, sir.
over to Dr. Kaushik.
Yes, very nicely done, Dr. Kangsa.
Thank
So
you.
my suggestion would be like, yes, include a pre-op ultrasound as Modi sir said, and the peeling of the fibrovascular proliferation, like this pull, like the centrifugal force which you put, it is a little risky, I believe. So sometimes it can, even though you did not approach it from the temporal side, you like some, but actually we cannot judge because intraoperative situation might have been different. But it is not a good idea to try to peel that off from the retinal surface, because specifically in the arcades the adherence can be very high and it can bleed torrentially. So there can be bleed and break if you actually try to. Better idea would have been like lift a little, find a plane and then cut, like try to segment it a little and then aim. So pulling this specifically near the arcades, I think it can be very dangerous, can cause bleed. And another thing is, like you can use a little tricot, triamcinolone. So it can help, specifically help in seeing the second membrane. Sometimes you feel that vitreous is removed, but if unless you put the triamcinolone, you will not be able to see the fine membrane which can be there in the posterior pole. And if you do not remove, sometimes the you saw now there was some bleed in the posterior pole also when you closed. So
Right.
sometimes they. Hello.
Yes, sir.
Dipanshu, am I audible?
Yeah.
Yes.
So I was saying, if you like, when you should, specifically in diabetic vitrectomies, you should definitely try to see whether there is a second membrane or not. And
Yes.
before closing the case, specifically in the posterior pole, try not to leave any significant bleed. And another
Right.
thing is that burn, which Dr. Devakant said, specifically around the disc, you also cauterize some way. So this kind of thing, if you do diathermy near the disc or very close to the disc, that can cause like pale disc, which like retina will be on, everything will be okay, but vision will not come. So that is another thing which I have learned by doing similar things. But yes,
Yes.
excellently done surgery, very nice. And did you put oil?
No, sir, we just did an FX and left it under air because there were no breaks that were encountered. And post-operatively also, there was no bleed. It was very quiet and everything was fine. Nothing went
Very,
wrong.
very nicely done, very nicely done. Thank
I have
you.
a question for the panel. Opinion on post, like while closing the case, injection, like intravitreal Avastin, a lot of people use.
Was
If they are,
given.
so is that given, and was that given, and what is the opinion of the panel on that?
Yes, sir, it was given at the end of the surgery.
No, I'm
Sorry.
just asking the panel, like, what's their opinion on giving intravitreal antibiotic at the end of the surgery? Does that actually help in preventing rebleed in the post-operative follow?
So Dipanshu, there is some literature which says that when you give intravitreal anti-VEGF at the end of the surgery, through mechanisms which are still not very clear, it helps in taking care of the small bleeders. And in some of these cases, post-operative vitreous cavity hemorrhage can be avoided if you are giving post-operative Avastin. But like what Akanksha said, it makes sense to, rather than that, also at the end of the surgery, lower your pressure. Akanksha, I will lower it to even lower, not just 30, but something
Yes,
around
sir.
10 to 15. And then
Yes, sir.
wait 2 to 3 minutes to see if there are any small bleeders which start bleeding again. If
Yes.
not, then you can probably get away without it too.
Thank you.
Yes, Dipanshu, this as Dr. Modi sir told, this is very important. Like you before closing, just keep the IOP low and see whether if there is any bleeder. Specifically, if you are not putting oil, if you are putting gas or something, then if there is a bleeder, then it will. And if there is hypotony post-op, then it will be bleed again. So yes, try to see whether there is any active bleeder, specifically in low IOP.
All right.
So I think we'll move on to the next speaker. Dr. Bobizon, if you can share your video, he'll be presenting Don't Fight the Membrane, a smarter way to handle TRD.
Dr. Bober is on the beach.
Yeah, he's on. Kyrgyzstan.
I think he needs to unmute himself.
Yeah. Dr. Bobizon, if you can unmute yourself also. He cannot hear you. Manjula ji, if you can help him out, he's using it for the first time.
Few minutes back he played, doctor.
But he'll be
Can
presenting
unmute him.
along with it.
Yep.
Yeah.
Yeah, yeah.
Do you hear me?
Yeah, we can hear you.
Okay. Hello to everybody.
Hello.
Okay.
Is there a sound to this video?
No,
Yeah,
no.
It's not audible.
yeah, it's coming sound. I will commenting myself during the video.
Yeah, you can
Yes.
comment.
Yes.
You can comment.
Yeah, at first we are going to bimanual dissection of membrane, but we can't understand where is the retina at the time, and we will decided to change our technique. We tried to peel from there, but we catch the breaks, and also we decided to put Helon under the membrane to create safe space for manipulating bimanual. So we're trying to dissect, injecting Hilon again to make more space to remove other membranes. And continues with bimanual. Anyway, during doing the bimanual, we have several breaks. So we're trying to change fluid air exchange. So and going to the lasering all breaks and finishing with pan-retinal laser coagulation and injecting silicone. Okay.
Thank you so much, Dr. Bobazon. That was an excellent surgery. Dr.
you.
Mudit sir, if you can comment on this and whether you use viscoelastic for dissection.
Prabodhan, first of all, a great case, very nicely done and very nicely illustrating how you can use viscoelastics to help you in identifying the correct plane and also in creating space for you to maneuver your instrument. So we have used viscoelastic for some of these cases and we have found that it works well. The only thing that we have to be careful about is first of all getting the right plane for you to inject. If you don't, and to be careful of your instruments. I mean, if you try to force it, and you may end up creating more breaks. If it goes subretinal, then your surgery is doomed. So, like what
Yeah.
you did, you were able to lift the membrane from the temporal edge, get a plane, then go inside and inject. So, and then it creates space for you. So there it helps a lot. So no other point from mine, but a very nicely done video. One more point is that you need to be careful of the peripheral retina. In a lot of these cases, like also in your case, the peripheral retina can be ischemic and thinned out. So at that point of time, if you try to pull them too much, then you will create breaks. So the idea is to not pull, but like what you did, either use, if you have a 27 gauge or a 25 gauge cutter, then use that as a spatula or as a dissector to create planes. Or if you can, then use, if you're doing bimanual, then use a scissor to go on creating plane. If you pull them vertically, you'll end up creating a break. So the idea is to ensure that your movements are in a tangential horizontal plane parallel to the retina.
Okay. Yep.
But in a nutshell, really a very nice video. Great
Thank
work.
you. Thank you.
Dr. Diva,
Karthik,
sir.
Kaushik, so nothing, Kaushik, Divkan, nothing else from my end. Great video.
Dr. Bob is on a very nice case, and this is one technique that we don't see often. For the benefit of the audience, would you like to tell us what benefit Helon gives us in comparison to a PFCL in such a case?
You mean to injecting PFC?
Yeah, for the same. Yeah.
Actually, I think when we injecting the Helon, it will be more stable than BFC, and it will be we can control it more easy. If you will inject BFC, any manipulating, it can be go under the retina because of the breaks. If you, even we have small break, so because of this, actually, I with my supervisor and mentor, it was his recommendation. We prefer the Helon.
Okay. Thank you. Very nice case. Over to Dr. Kaushik.
Thank you.
Very nice case, Dr. Bhapijan. So, like the membrane was very white or like very avascular. Did you give intravitreal anti-VEGF before the injection, or it was like this? Pre-op
No,
anti-VEGF.
actually, no, we didn't do before, but after controlling, we didn't find anything for injection. But when we finished the cases, after a few weeks, we sent the patient to the own CT for controlling by own doctor.
Okay, very nicely operated. And I'll say, like what I do is whenever there is a break, it might be a good idea to mark those breaks with a diathermy, because sometimes after fluid air exchange, you might like they might get lost, or you might
Sure.
not be able to determine where they were. So
Yes.
but otherwise, very nice surgery and very nice case. And you
Thank you.
did the bimanual surgery very well, very stable hands. Thank you.
Thank you. Thank you very much.
Just a question to the War Council: if you are thinking of giving anti-VEGF in diabetic cases, then how long do you wait after the anti-VEGF?
If we are doing, you asking for me or I'm sorry?
Please
Yeah,
continue, Doctor.
you
Yeah.
can also come.
Actually, if we are going to anti-VEGF, we are waiting about 2 weeks only.
So you operate after 2 weeks of
Yeah.
giving the
5 days for me.
yeah.
Yeah.
Yeah, we
So
also do 5
if there
days
is
only.
traction, 1 to 5 days, 1 to 5 days for me. So if there is traction, I don't think it is a good idea to wait after for 2 weeks, because by that time that if the macula was on in a tractional RD, it will be definitely off, and there will be crunch. And also what Dr. Akansa said, you need to ensure that the such patient will be able to get operated at that
After 5
time,
days.
after like within 1 week or so. And if they are not controlled, not willing for surgery or something like that, so you better do not inject, specifically if there is TRD or traction present.
So I think we'll move on to the next presentation, which will be by Dr. Ashul Chawla. Uh, he will be presenting on precision vitrectomy in PDR, managing complex FPP. Dr. Ashul, if you can share your video.
Yeah, hello. Good evening. So what I have done is I've curated a series of cases for the same. So I'll just be sharing. It has a voiceover as well. Diabetic vitrectomy is one of the most challenging surgeries in vitreoretinal practice. Its success hinges on the advanced surgical skills and knowledge of the pathology involved. Recent advancements in vitrectomy technology, such as small gauge instruments, have significantly improved both anatomical and functional outcomes for the patients with diabetic retinal detachments. While approaching the vitreous, remove the vitreous from the two superior ports to avoid vitreous incarceration and peripheral retinal tears. After clearing the vitreous from these ports, remove the vitreous behind the lens while taking care to spare the posterior capsule. If the hemorrhage cannot be cleared well enough, a phakic eye lensectomy may be necessary. In majority of traction retinal detachment cases, the core vitreous requires no specific attention. And the first step in any case of TRD should be to trim and release peripheral vitreous on 360-degree. One should avoid going directly to the nerve to induce a PVD or initiating membrane dissection until peripheral vitreous bone has been trimmed. This is because the vitreous at the nerve can invariably lead to iatrogenic tears in the peripheral retina if pulled. In some patients, peripheral vitreous may be tightly adherent to the retina. In such cases, one should apply a little more suction with a cutter to release the vitreous from the surface of the retina. This seems difficult. One can slide the cutter tip through the adjacent trimmed edge of the cone to lift the adherent vitreous. Once the peripheral vitreous has been released, attention is turned to the posterior pole. Now, segmentation and delamination are the two major surgical techniques in membrane removal. In simple terms, segmentation is cutting the fibrotic epiretinal membranes into small segments or islands, and delamination involves removal of these segments from the surface of the retina. In area of insedation, lifting FEP slightly with forceps to create a plane or viscodissection can be used. Segmentation can be accomplished either with cutter or scissors. Advances in small gauge cutters, such as location of the port closer to the tip and improved fluidics, and allowed surgeons to use these instruments as vertical surgeons. To initiate segmentation process, blunt tip pick or the cutter tip is first carefully guided between the membrane and the retina, and the space is created by moving the instrument sideways to sever the adhesion. Because these membranes are elastic, they usually swell up a little once the adhesions are severed. Cutter port can then be inserted in the space between the membrane and retina to cut or segment the membrane. After we have created a segment or island, we proceed to delaminate or remove that fragment from the surface of the retina. Now, full bed taken. A cutter is placed on the entire surface of the membrane and vacuum is used to separate the membrane which folds into the cutter. Hemostasis. One must control bleeding early and throughout the surgery. Uncontrolled bleeding can obscure the source of hemorrhage and can form pseudomembranes, leading to further difficulty in membrane dissection. Elevated IOP or fluid air exchange can help controlling the bleed. In summary, diabetic vitrectomy is a meticulous procedure with high demands on the surgeon's skill and equipment quality. By following structured steps, surgeons can achieve better outcomes, preserving both vision and quality of life for their patients.
So your comments on the video, please.
No, nice videos, and I think you have shown the steps pretty well in terms of what all are the basic steps that everybody should know when they are trying to take care of the tractional detachments and the membranes that are there. And bimanual also comes to a help. It's important to understand how good technique segmentation is, and it's a game of patience. You need to slowly keep on segmenting, trying to divide the membranes into smaller and smaller pieces, and then trying to eat them up. Taking care of a secondary membrane is one of the most important steps in any TRD. Once you have taken care of that, it helps you in identifying the correct plane also. It helps preventing traction. It helps prevent future bleeders, future membrane formation. So that is again a very important thing. And a careful diathermy intermittently and without getting late. So a lot of times people do this mistake. I've seen fellows do the same mistake. They keep on dissecting the membrane and in the process forget what's happening to the other side, and then that blood gets coagulated. You have got a thin ischemic retina, that clot gets adherent. You try to lift it up, you create a mess or a break. Your surgical plane goes for a toss, things become less visible. So at every single point of time, it makes sense to stop, cauterize the bleeder, and then move ahead rather than going on dissecting, forgetting about the adjacent bleeders. So dissect, stop, cauterize, dissect, stop, cauterize, and ensure that your field is as blood free as possible. That's it. Dipanshu, Karthik, Kaushik, Devkant.
Yes,
Those are the points from my end.
Deva sir.
Nothing much to add. So, sir has and Dr. Chawla has already demonstrated very beautifully how these surgeries should be performed. Luckily, we had presentations all on diabetic vitrectomy, and it's a very nice. This talk has summed up all these things that we would have wanted to discuss about. So, very nice presentation, very well documented and illustrated. Thank you so much. Yeah.
Kaushik
Very
sir.
nice, Dr. Asuri, very nice. Everything like all the steps have been discussed, and yes, it is a diabetic vitrectomy day, I think, today. So, Dr. Modi sir has already like summarized everything. My it would be like systemic control is very important, specifically if the patient is on dialysis. So these patients are very difficult getting dialysis every 3 times a week, etc. So they are on insulin or heparin. So the bleeding can be very difficult to control in such cases. So yes, try to like get hemostasis properly. And what I have seen is that preoperative anti-VEGF does help. A very useful adjunct if you can use it very nicely. And yes, as I told, control the bleeder at the when you are seeing that. So do not wait ki it will, and sometimes it actually becomes like thick membrane kind of thing, and it will not come. It just sticks to the retina. So this is whenever you are seeing a bleed, just cauterize it. And Dr. Asul, the laser, the PRP was like a dream. Very nice, very nice laser you have done.
Thank you, sir.
It is like a book image. Very nice photo. Thank
Thank
you.
Thank you. Sir, I also had one point to add. In case of heavy bleeding, what we used to do, our mentors used to do in SN, they used to check the blood pressure as well. Sometimes patient gets anxious and his blood pressure rises up, which in fact leads to heavy bleeding. Sometimes just talking to the patient might help you in controlling the bleeding as well.
It
Ashok,
can
that's
go,
actually a
it
great
can go
point.
other ways. It can go
Sorry,
other
Dr.
ways
Kaushik was
also.
saying.
Yes, yes, sir.
No, please go ahead.
So it can go other ways also. Sometimes there are few very anxious patients. If you start talking, they'll just move their head and talk and make things difficult. So it is, well, sometimes it is better to stay quiet and just get the job done, because sometimes patients may be very difficult. And in some cases, you might have to have anesthetist with you, so who can actually lower the pressure. If you can actually decrease the pressure, then the bleed can actually reduce. And if you can put the patient in a like anesthesia, GA or IV anesthesia, then also the surgical control might be more. Yes, Modi sir, please.
No, I think the BP point was very valid. In fact, if you look at lot of oculoplasty surgeries or corneal reconstructive procedure like keratoprosthesis, they ensure that there's a bit of a hypotension so as to prevent too much of bleeding. So that is there. You also have to be cognizant of the systemic parameters. Sometimes patients who are like what Dr. Kaushik said have got a compromised renal system, they have a higher likelihood of also developing a pulmonary edema. So you need to be careful about the systemic evaluation. That becomes very important when you take these patients for a surgery. So for all TRDs, it's important to check the renal parameters also, and also to see what's the systemic control. So those are few other points which apart from a surgery will also make a difference in your final outcomes. But once again, thank you, Ashul. Great case and great collection of steps and videos.
Thank you, sir. Thank you.
I have a question to the panel. So, in diabetic weights, whenever there is a peripheral retina visible, there is no hemorrhage, and there is only either a tabletop TRD or TRD involving macula. What is in your opinion, what is the role of PRP prior to surgery? Because it is said that it helps in dissecting the membrane better, and membranes can be peeled off, like these FEPs can be peeled off in an easier way.
So it depends. If you have got too much of a peripheral membrane, if you have decided that you are going in for a surgery, then I prefer not to get a laser done. I realize that I can do it at the same time. The other thing that sometimes happens is when you do a laser, your vitreous gets adherent. So removing the peripheral vitreous actually on the contrary becomes difficult. So there are two things we are talking about, Dipanshu. One, if you do a preoperative laser for the thought that probably it will save you work during surgery, number one. Number two, there may be some fibrosis that may happen over a period of some time. Then that's a different issue. If you are thinking that you will do a laser, there is not much of a traction, not much of a membrane, just a bit of a hemorrhage that will go away and that will help you in avoiding or preventing a surgery altogether, then go ahead, do a PRP. But if you have already decided that this is a patient who is going to need a surgery, then I don't get a pre-op laser done.
Any difference of opinion with Devasar or Kaushik?
So if the retina is visible, specifically superiorly, and if the patient is uncontrolled, or I know that like surgery might be very difficult, so I will laser the peripheral retina as much as possible so that the time reduces. But yes, peripheral specifically in periphery, we usually, and it is in diabetes, it is very difficult to. It may be very difficult to proceed with PVT like beyond very anteriorly, specifically in the nasal part. So in the nasal retina, the vitreous might be very much adherent. So yes, obviously posterior pole has to be like vitreous should be removed from the posterior pole and all around all the retractions. Yes, I usually, if I have a time, and if the patient is not like going for surgery or not willing, etc., then I'll do laser. But if I know that patient is going for surgery within week or so, then usually I get it done in the surgery itself. Dr. Diba?
Things, I don't know.
So may I make
Karthik,
I make
Yes,
yeah,
yes, please, Dr. Asun.
Yes, sir, I think the intensity of burns also matters. So sometimes the patients come with heavy, very heavy burns. Those vitreous get very much adherent, and they are those are very difficult to peel off. But I don't know about that small, away from the FPP, light burns which are away from the FPP might help. But in my opinion as well, I agree with. I'm so sorry, sir, but I agree with Mudit sir only that I don't laser pre-op because the adhesion of that vitreous. But the burn intensity, light burns away from FPP might, in fact, be helpful.
Okay, I think great point discussed. We can move to the intravitreal talk now. And meanwhile, we'll calculate the score. And after the first intravitreal talk, there will be scoring for the audience poll. So please stay connected, and then we'll have the winner at the end of the talk. Thank you so much. Thank you all the War Council for your valuable comments. I'll invite now Dr. Gaurang for this intravitreal talk. Thank you.
Thank you, Dr. Karthik. I hope my screen is visible.
Yeah, it is.
So on the outset, I'd like to thank YOSI Council and the Bayer for this opportunity to present my experience with ILIA. So clinical practice, we all know that ILIA has been used for AMD, DME, and other conditions. Here I am basically to discuss some of cases of PCVs and RVUs and some atypical MNBs where I have injected ILIA and have got good response, and also some normal cases. So this is a one-eyed case, a 50-year-old male which came to our clinic. The other eye was already vitrectomy for TRD, isofilled elsewhere, and macular pucker. The other eye, if you see on the OCT, had intraretinal cyst, a good amount of IRF, and being a one-eyed patient, I plan to go ahead with ILIA, and the visual acuity improved from 6 by 36 to 6 by 12 in just one injections. I continued with the loading dose of 3 injections, and the retina went back flat to normal, and the one-eyed patient eventually, after 3 injections, was dramatically improved from 6 by 36 to 6 by 9 parts. So the drying effect of ILIA was very superior in these one-eyed case. Similarly, this is a very recent case, a 72-year-old female walked into my clinic with DOB since 15 days. She is a known hypertensive. We can see there's a RVU in the fundus picture as shown on the right side. And if you look at the OCT, the starting OCT, there is loss of retinal architecture with a lot of edema inside. So we went ahead with the first anti-VEGF. The presenting visual acuity got 4 by 60. But over the course of 3 injections, the visual acuity came back to 6 by 24. And as you can see over the serial OCTs, the retina is getting back to its normal architecture, the fluid is reducing, and the visual acuity is improving. Even if you could see the infrared picture on the right side, the hemorrhage is also reduced. She is still on my follow-up, and I plan to continue with the same injection. This is case number 3. He's a 55-year-old pseudophakic male, and he has DOB since 15 days. When you see this very classical OCT of PCV, and you can see there's a big polyp which is sitting there. And the visual acuity is 4 by 60. And this is the OCT which is passing through. And as there is not much subretinal component of subretinal bleed there, I planned just plain anti-VEGF first. And with the this is the fundus picture, you can see a classical PCV sitting there. And with just one injection, the polypoid vessel actually regressed brilliantly, and the visual acuity came back from 4 by 6 to 6 by 24, which is very commendable. Of course, it requires more number of injections to completely suppress that Pachy vessel which is sitting there. So it's still on my continued follow, but I just wanted to show that even with one injection, the results are actually fantastic with ILIA. This is a 63-year-old female, 63-year-old male, which walked complaining of metamorphosia. This was a classical AMD picture, as you can see in the right eye. So this patient had 6/12 visual acuity. In this case, the patient was actually being on a biosimilar of ranibizumab for quite a long time, and again we tried to continue the same, but the patient was not improving even after 2 injections. So this became a case of non-responder, and I tried to shift and counsel the patient to shift to aflibercept. And this is the first time I gave Eylea, and if you can, even just after 1 injection, the MNB has started to reduce, the fluid has started to dissolve, and the visual acuity has come back to 6/9 parts. I continued giving, and the drying effect and even the MNB constriction can be seen, and the patient is maintaining pretty well, and the fovea is almost back to normal, and the patient is having a visual acuity of 6/6. This is a case in which the patient is a non-responder to biosimilars and switched to Eylea. This is a very interesting case. A 16-year-old schoolgirl walked into my clinic, and this is the fundus picture. If you can see on the right side, there was a small patch which was seen in the superior temporal periphery, and this is the OCT passing through it. So for my first differential was infective etiology. So I worked up for all the infective etiology, and it came out to be negative. There was no history, any significant history of trauma. The patient was not myopic, so I categorized it like an idiopathic CNVM. The patient was having, I planned, the patient was still complaining of visible waviness and metamorphosis, so I planned to go ahead with Eylea, and the patient had 6/18 parts visual acuity. And you can see as the after the first dose, the size of the CMM has actually improved and has decreased a lot, and patient visual acuity has also improved to 6/12 parts. And after the third dose, again the MNV has gotten shorter. I could not share octa pictures, but the considerable neovascularization has gone down, and the patient has returned back to almost normal visual acuity. So he's still on continued treatment. And this is my last case. A 21-year-old female walked into our OPD. She had DOB since 2 years. Presenting visual acuity was 6/18 and 6/60. The B scan showed hyperreflective membrane with acoustic shadowing. There was similar picture in the other eye, so we made a diagnosis of osteoma induced CNVM. You can look at the octa, which is on the left side, and the size of the CNVM. We plan to go ahead and inject aflibercept, and just in one dose, the visual acuity has improved from 6/6 to 6/12 parts. Is actually miraculous. Even if you see on the octa, the fuzziness has reduced, the neovascularization size has reduced, and similar corresponding picture on OCT, you can see the fluid has gone down and the membrane has constriction. Unfortunately, this patient was lost to follow-up, but even with one injection, I think it was very commendable visual acuity this Eylea. So this was my short experience with Eylea. Thank you so much for your time.
Thank you so much, Dr. Gorang. Those were wonderful cases that you presented. Dr. Kaushik, sir, if you can comment on this. Kaushik, sir.
यस वेरी नाइस केसेस. डॉक्टर गौरंग, आपके पास वो फंडस फोटो है क्या उसका ऑस्टियोमा?
नहीं सर, वो एक्चुअली में इट वाज आई हैव द बी स्कैन. मेरे पास फंडस फोटो नहीं है सर. वो एक पेशेंट, एक हैंड, इट वाज एक्चुअली लॉस्ट टू
नहीं,
फॉलो.
आप फंडस फोटो ना, आपका जो रीमेडियो का एक बहुत कम पैसे का फंडस फोटो रहता है, बट आई थिंक इफ यू आर प्रैक्टिसिंग रेटिना, एक फंडस फोटो का रखना चाहिए, ताकि जो ऐसे केसेस हैं जो थोड़ा एकेडमिक इंटरेस्ट है उसका फोटो ले पाए, क्योंकि ओसीटी में आपको दिखेगा नहीं. बट यस, वेरी नाइसली मैनेज्ड एंड गुड केसेस.
Thank you, sir. So we'll move on to the next presentation. Dr. Ishwak, if you can share your screen. Dr. Ishwak is from Kashmir Eye Hospital and he's practicing in Srinagar. We'll be talking about aflibercept in wet AMD and DME, case-based insights.
Good evening, everyone. Am I audible?
Yes, yes.
I will be presenting my efficacy of aflibercept across the pathological spectrum. This is a case-based insight. I will directly go to the cases. I will first present a case of 67-year-old male with the best corrected visual acuity of 636 both eyes. He has received multiple ranibizumab injections in both the eyes, but he had persistent diabetic macular edema. This was the presentation when we switched to aflibercept injection for the right eye. There was, at the end of 1 month, we can see there was significant decrease in central subfoveal thickness, and visual acuity improved by 1 line. And this is the left eye of the same patient, in which there was significant, the macular edema has decreased, but there was no significant improvement in visual acuity, because the subfoveal ISOS disruption is seen in this case. I have one more case. It's a case of 67-year-old female with proliferative diabetic retinopathy with DME in the right eye and severe NPDR and DME in the left eye. In the right eye, the patient had received already multiple Avastins and one Ozurdex also. There was still the macular edema with hyperreflective dots. I changed I switched to an aflibercept injection. Just at 1 month, we can see the macular contour. The foveal contour seems normal with fine ERM and 1 line improvement in vision also. And this is a similar case, same patient in the second eye. And she had chronic edema, macular edema after receiving multiple injections. Though I have given actually aflibercept in both eyes on the same day. You can see there is decrease in macular edema, but visual acuity has not improved as such. One more case with non-proliferative diabetic macular edema and diabetic macular edema, and non-proliferative diabetic retinopathy with macular edema left eye. Patient has previously received 2 ranibizumab injections. Still, the macular edema was persistent. Then we switched to one more this aflibercept injection. 1 month post-op, there was decrease in macular edema, and visual acuity was 612 at the end of 1 month. This is an interesting case in which the patient had uncontrolled hypertension with diabetes. It was a mixed type of retinopathy with macular edema with significant subretinal fluid. That patient also had received Ozurdex and 2 Avastin injections. Macular edema was coming just 3 to 4 weeks after getting the anti-VEGF. He had not any improvement. Then after receiving Ozurdex, patient was shifted to Ozurdex because of raised creatinine levels. And then still there was this persistent edema. We have shifted to aflibercept injection. At the end of 1 week, there was significant improvement in macular edema and subretinal fluid was gone. But the patient had some systemic issues and was on dialysis. He could not come for follow-up. We could see just 2 months after the first injection, patient had persistent intraretinal fluid with no subretinal fluid. I advised the second dose. This is the 1 month, in the last picture showing the macula 1 month post second injection, and there was significant improvement in visual acuity also. I have one more patient with recalcitrant DME, had received multiple anti-VEGF injections before. In that patient, after giving aflibercept injection, there was significant decrease in intraretinal fluid, but the visual improvement was not significant. After receiving the second, this patient had lost follow-up and came just 4 months after the first injection. After giving the second dose and the 1 month post second dose, here there was significant improvement in visual acuity as well as the edema was coming down. These are the, I would say, 5 DME, different types of DME patients that I presented here. Thank you.
So great guesses, Dr. Ishfaq. Manjula ji, can you start the audience poll? Meanwhile, we'll discuss.
Sure, doctor.
इस्पाक आज डायबिटीज का डे हो गया. वेरी नाइस केसेस.
Thank you, sir.
और इसमें
Okay.
इसमें आपको पार्ल भी दिख रहा है. पार्ल जैसा जो अपीयरेंस बोला हुआ है ना,
Yeah,
ओसीटी
exactly.
था वे करके. आपका पहला एक केस में ड्रिल भी था, डिसऑर्गेनाइज्ड इनरेटिनल लेयर.
Outer,
हाँ, वो फर्स्ट केसेस में था. वेरी नाइसली एक्चुअली आइलिया इट वर्क्स वेरी नाइस.
and I have seen patients who are, I will say, nephropathy also, who have nephropathy also. This aflibercept works very well, and we have not seen any increase in creatinine levels that we commonly see with this bevacizumab or ranibizumab also.
एक्चुअली ये भी एक अलग सा, आई थिंक इट इज ए गुड एरिया ऑफ डिस्कशन की whether anti-VEGF injections can be attributed to nephropathy etc. Mudit sir.
Mudit sir had to leave somewhere.
Okay.
But
So basically, Karthik, what are the other opinion
as
of
of
other
now,
members?
I think as of now, from the nephrologist side, only aflibercept is something of all the anti-VEGF which has got clearance for people who have CKD and are on dialysis. Or for other anti-VEGF, they somehow all the good nephrologists they ask us to avoid. So either you can give Ozurdex, that is dexamethasone implant, or aflibercept. They give clearance. So this is what I know for now.
What about the other anti-VEGF? When do you think of not injecting other anti-VEGFs except for Eylea? If the creatinine level is at what level? Do you have any level, or is it just when the patient has CKD, you ask the nephrologist to comment on it? Kaushik sir?
Actually, we never ask the nephrologist because most of the times they will tell their patients to avoid any anti-VEGF. But I have seen Ozurdex as well as aflibercept working very well. Ranibizumab is also very safe, but I have few patients in last 1 year only who actually they had severe pedal edema after getting ranibizumab injection. And you cannot explain that. I don't know, to be very frank, clinically, you cannot explain that how just after getting injection ranibizumab they had pedal edema.
Basically, my point is you are giving 0.05 ml, which is very little amount inside a cavity which is not vascular. How it is, it may cause renal disease, but I think this association is more of a speculation than of a real connection with this. If you have to prove that it is causing this, you need more data on that and more consistent data on that. This thing is dangerous for kidney disease because that. And yes, certain this nephrologists are not very much. Whenever they hear that they are getting anti-VEGF, they'll say no, do not get it done. So I usually prefer dexamethasone implant for such cases.
Yes.
But sometimes we have a problem because in some patients, if there is raised intraocular pressure, you cannot give acetazolamide orally, and much mannitol you cannot give, and that is a problem. Otherwise, that is very safe.
Should we announce the winner?
Kaushik sir, I have one question regarding that Helon implantation that one surgeon used Helon for membrane dissection. Is it easy to remove Helon at the end of the surgery? Kaushik sir?
Dr. I actually missed your A.
I was asking about the Helon. If you peel the membranes with using Helon as a how easy it is to remove the Helon? Is it easy to remove with the
I have
25
personally
gauge?
not used Elon. I do not have any experience on that. Dr. Karthik, Dr. Pranav, or Dr.
I've
Any other-
used Helon once. It's not very difficult to remove. Actually, you can just aspirate with the cutter once you've removed all the membranes. But I also don't use it very frequently. I think Dr. Bobir
Yes, Dr. Bobby
would
is
be a better
I
person
can
to
answer,
answer.
yeah. Actually,
Yeah.
it's not very difficult. You can remove it very easily. It will come very easy.
Very
And because of you are using not very heavy Hilon, it's about 2% only.
Sometimes after if there's a nucleus drop case, the visco actually drops down and it's on the surface of the retina if you're doing, and I think it
Exactly.
easily comes into cutter. I have that much experience of whatever nucleus drop cases are actually referred.
That is usually HPMC or use.
Yeah.
That
The same. We use HPMC for avoiding that
Yeah.
tugging in the
Yeah,
pseudo.
yeah.
I do have same experience.
Same experience.
I have seen HPMC actually coming easily with the cutter, not with the extrusion tip.
Yes.
Because with cutter you can use, you cut it, but with the 25 gauge extrusion with soft tip cannula. But in that case, it becomes slightly difficult.
So, is there any other questions from the panel if you want to ask? Anyone else? So I think we'll announce the winner. So the winner for this session, it was a very close fight, and but the results say I think Dr. Manjula ji will announce the winner if she can.
No, I think she doesn't have all the score.
She doesn't have. So the winner is Dr. Bobir for his excellent presentation for the membrane dissection video with the Helon. Dr. Bobir, thank you so much. It was
Thank you. Thank you very much.
wonderful video, and we got to learn a lot. And
He will also be joining us for
congratulations.
the YOSI in New Delhi. We'll see you there.
Yeah,
Thank
we'll
you.
give
See
you
you.
an invite for that. We
all
hope
all the
we see you
presentations
there.
were very nice.
Yeah,
Very nice.
it was a good diabetic day.
Good diabetic
Yes.
day, and all the presentations were great.
Yeah,
So,
excellent.
first of all, I would like to thank our War Council, Dr. Mudit Tyagi sir, Dr. Kaushik sir, and Dr. Divakant sir, for always taking out time and giving out their such valuable insights. I would also like to thank Dr. Bobir, Dr. Ashul Chawla, and Dr. Akanksha for participating as warriors and presenting their exceptional work. Also, Dr. Gorang Sehgal and Dr. Ishwak for giving us insights about aflibercept in wet AMD and diabetic macular edema. And in the end, I would like to thank Bayer for supporting us in this venture. Thank you, and see you all soon for the next episode.
Thank you. Thank you so much.
Thank you, everyone.
Thank
you. Good day.
Good day.
Good night.
Everyone.
Good night.